Immunotherapy has altered the treatment paradigm for patients with advanced non-small cell lung cancer. Without a driver, you now have the option to use immunotherapy up front with chemotherapy, which I don't do yet, and this would be the carboplatin pemetrexed with pembrolizumab. In an unselect patient population, you don't need a PD-L1 to make that decision, you can do it. And then if you're not going to use it up front, it is one of the options for second line. And again, independent of PD-L1. Atezolizumab, pembrolizumab, nivolumab all can be used second line. Atezolizumab and nivolumab can be used independent of a PD-L1 score, second line. Pembrolizumab, if you're going to use it second line, has to have a tumor proportion score greater than 1%. So it has completely altered the way that we view lung cancer, the way that we think lung cancer behaves, the way that the immune system interacts with the cancer. But we have a lot of options, and I don't know if we know yet what the best option is. Should we use immunotherapy up front with chemotherapy? Should we save it for second line? Are there other combinations that may work better? So that's really the role for immunotherapy. Immunotherapy is great, and I'm not saying that I'm not excited about immunotherapy. It doesn't work for everybody, and I think that's really important. And again, the advertising campaigns would make you think that it works for everyone, and it doesn't. If you look across the board, even in the second line, the response rate to single agent checkpoint inhibitor is 20%. 80% of patients don't respond. So we've got to do better, and we will, but I want to temper the enthusiasm. I'm excited and want to move this field forward, but we have to be mindful of what the actual data shows. Immunotherapy probably is not the best drug for patients with driver mutations, specifically EGFR and ALK. If you look at subset analysis of patients who are, from these trials, and the subset analysis of patients that were EGFR mutated, in every trial they did better with docetaxel than they did with immunotherapy. So these specific genotypes are generally not the ones that we really are enthusiastic about using immunotherapy. Retrospective analysis on very small data set, the response rates of patients with EGFR mutations treated with the checkpoint inhibitors around 5 to 10%. Response rates to ALK-rearranged lung cancers to immunotherapy, 0%. Again, very small numbers, but I think we're learning that these specific genotypes are not the ones that are best candidates for immunotherapy. Yeah, I think that the two scenarios where I see immunotherapy as probably not my first option is one, in a patient who's either EGFR or ALK-rearranged who's received targeted therapy and then gotten chemotherapy, or even received targeted therapy in which you're entertaining immunotherapy second line rather than chemo. I'm not sure we know how to sequence immunotherapy for these patients that are EGFR or ALK. Again, the data would suggest that docetaxel is better than immunotherapy. So that's a one patient group. The second patient group is one we've talked about, which is the rapidly progressing first-line patient. So a patient who's getting 4 cycles of chemotherapy, they are rapidly progressing, their PD-L1 score is low. These are patients in which you need to elicit a response. And if you look even at the subset analysis from Checkmate 057, which is around 108 patients had low PD-L1 scores, less than 1%, the response rate was only 9% to immunotherapy, half of what it is for the intention to treat analysis. So that would be my second scenario scenario where I would, not saying I wouldn't use immunotherapy, but I think very critically about what I'm going to do second line. And then obviously the third scenario is a patient that just not going to be able to tolerate it, a patient who's on steroids in which you're blunting the effect of the immunotherapy that you're giving, or a patient who has an autoimmune disease. This is 3 broad scenarios, and I'm sure there are others that I would critically think about how I'm going to do things. PD-L1 expression as a predictive marker to these 3 agents, nivolumab, pembrolizumab, or atezolizumab, really depends on what line you're thinking about. And I'll go first line first. We know that PD-L1 expression greater than 50% is the predictive biomarker for pembrolizumab upfront. That's clear now, and every patient who has a TPS PD-L1 expression score greater than 50% should get pembrolizumab. If we look at pembrolizumab in combination with chemotherapy up front, it didn't matter what the PD-L1 was. And in fact, in the low PD-L1 patients, there was a response rate that was quite high by adding pembrolizumab. So the jury's still out on that. In the second line, if you look across, I'll make a very general, broad statement. If you look across the board in the second line, For the most part, the higher the PD-L1 expression for these patients, the more likely they are to respond to either pembrolizumab, atezolizumab, or nivolumab.